Okay. Hello, dear students. How are you? How was your test today? I hope you did great. Though I have not given the topics which I have only covered so that we can discuss more topics and more questions and more answers you will know for your exam. So not the same thing that I've told, same questions have come. I'm very sure of that. And we have included a lot of memory based and also video based questions and image based questions this time. As you would have seen in this test, I all request you all guys first do the test and then see the video. Okay, those who have not done the test now have joined live. Yes, we will discuss for sure, but remember, first always do the test. Whenever you're saying later date, maybe first do the test and then see the video. Okay, then you will know where you have gone wrong, why you have gone wrong. That will be the best way to assess yourself before your exams. Okay, after your revision, do a test. Do revision, do test. This is how you should progress from now onwards. Okay, revision and mock test. These are the only key right now. Do not try and study any new topics. Okay, so good evening everybody. So we will start the session now. Okay, so let us begin with the first question. Okay, can you see my slides? Please confirm me if you can see my slides and also you can see the audio visuals. Both are all are fine. Then we will continue with the class. Please confirm me somebody that you are seeing the slides. Is the first question visible for everybody? No. Okay. No, it's not visible. Okay. How about now? Now you can see now. Just move 2 3 slides so we can have a better clarity whether you are seeing or no. Is the second question came and the third question also, is it moved? Yes. Okay. Shivam has confirmed me that he can see. Yes. Okay. Now let us start with the first question. Okay. So everybody is confirmed. Yes, you can see. Very good. Okay. So let us start with the first question. Yes, you can see first question, right? Okay, I think the delay, the lag was there. That is why I had to reshare my screen. Now you can see, that first question is here. Yes, now you can see. Okay, this is a first question, which is a pictorial based. Okay, 17-year-old girl with severe cyclical pain abdomen. Okay, severe cyclical pain abdomen is there. Diagnostic laparoscopy reveals findings shown in the image. Okay, in diagnostic lab, what we will see? We will see the uterus and the ovaries. Okay, what is the most likely diagnosis? So you can see collection of chocolate fluid or endometrioma here. So it is a collection of fluid. Endometrioma is there, which is being collected. Okay, that is the main reason for why she's having this here. Okay, so the main most common reason for chronic pelvic pain in adolescent age and the reproductive age group is because of endometriosis. Okay, when it is chronic, persistent, not subsiding, always because of these days delayed marriage and hormonal imbalance, lifestyle changes, all those things, endometriosis has become one of the commonest cause for dysmenorrhea. Okay, and you can see cyclical pelvic pain, mostly menstrual related. Okay, then menstrual related, that's why cyclical. If it is a dermoid cyst, it is not something which is cyclical, isn't it? So it is there forever, dermoid cyst. So it's not because of dermoid cyst. The same with the corpus luteum. Corpus luteum is a small functional cyst. Okay, it is there for everybody every menstrual cycle, but because of that there is never a pain. You understand that? Even if you do not know the image, by ruling out technique, this cyclical word, just with this you can rule out the other three options very easily, isn't it? So always do not try and imagine only one thing. Okay, what is the image? I'm not getting. Do not break your head like that. See the question, pick up the important points from there, see the image. If you can correlate both of them, and you will come to one answer here. Okay, coming to cystic serous cyst adenoma, this is also a benign tumor, isn't it? So here, first of all, adenomas, cystadenomas are not painful unless they become torsion, severe in size, or there is some hemorrhage inside that. Okay, otherwise they are not usually painful. Again, here, even if it is painful, it is not cyclical, it is always a continuous kind of a pain. But whereas endometriosis, most of the pain comes during menstruation. And what type of dysmenorrhea does endometriosis have? Yes, what type of? There are two types of dysmenorrhea. Primary, secondary, you can say, or you can say it as, yes, congestive and spasmodic. So which type of dysmenorrhea is endometriosis? Please answer me now. Yes, very good. It is endometriosis, endometrioma. Everyone is correct. Which kind of dysmenorrhea is seen in endometriosis? Congestive kind. Very good, Shruti. Correct answer. So congestive kind is where the pain or the menstrual pain starts even 2-3 days prior to that of the menstruation. Okay, they'll have pain 2-3 days prior, and it is there throughout, and maybe 1-2 days later also. Okay, whereas spasmodic, it starts with menstruation and stops with menstruation. And this is even in the primary. Whereas secondary, where there is some pathology, it is congestive kind, like our endometriosis. Okay, remember, they would have given you a description like this now, saying, okay, a 17-year-old girl comes to you with cyclical pain abdomen, which starts 2 to 3 days prior to that of menstruation, and it is there throughout the menstruation. This is what type of dysmenorrhea. Okay, like this question also can be asked. Okay, that is why I've given you a description. So this answer, everybody is understood, everybody is clear now. Yes, okay, now let us go ahead with the second question. Okay, this was a video based question. Okay, since your recent FMG had so many video based questions, we have tried to add, because remember, usually whatever comes in INICT, those topics are very likely to be asked in NEET exam. Those topics which are in FMG likely to be asked. So we do not want you to miss out in any likelihood questions. So that's why we have given you a trip. That's why we have given you this video based image also. Okay, now this is a transvaginal video. Okay, when we are doing a transvaginal scan, this video has been taken, and which demonstrates the endometrial appearance. For now, in this you should be able to understand. Very difficult for an UG level, but still I am showing you. This is the uterus. Okay, this is the uterus. You can see now. So this is the uterus. So uterus outer layer and this is the innermost. The innermost is nothing but the endometrial layer, isn't it? So they are asking you what kind of endometrium is this? When do you see this endometrium? That is the question, isn't it? So now this ultrasound finding most commonly seen during which phase of menstrual cycle? So now remember, during this layer of endometrium, why is it important? Okay, whatever phase, what for us, it is not like that. This phase of endometrium is very important for us. Why? Whenever we do an embryo transfer or even a simple ovulation induction or IUI, what we will see is this endometrium. Is this endometrium a triple layer? You can see hypoechoic, hyperechoic and hypoechoic, like that layers are there in the center. You can see here in this video a hypoechoic, this inside layer. I'm trying to show you this inside layer. Hypoechoic, hyperechoic and hypoechoic. This is nothing but the triple layer. Okay, the triple layer. So this triple layer is very important. If this triple layer is there, means the endometrium is very receptive. Now if you put an embryo or if you do a IUI, there is very high likely chance that implantation would do good. The endometrium has grown enough that the implantation can happen now. So that is why this triple layer is very important. So when do we do IUI or ovulation induction? When we do, we will see this triple layer. Then we will do the IUI. So when we will do? Just before ovulation, isn't it? So when you, now you can tell me the answer based on this. Yes, Digvijay Singh has answered for this question, I believe, because he has already answered the second question. Second is congestive kind of dysmenorrhea. So he's given one more option, B. Is this for second question? So when do we do IUI? Okay, before ovulation, after ovulation, or when do we do IUI, intrauterine insemination? We'll see this triple layer. Oh, triple layer is there. Endometrium is very good. Now, if we push the sperm, the embryo will get fused and it will get adherent. No problem. This is a good endometrium. This is a receptive kind of endometrium. Yes, Shruti, the correct answer is B. Pre-ovulatory, isn't it? Just before ovulation, the late proliferative phase. Let us say day 13 or day 14. Let us say she's ovulating on day 15, 14th day we see this. Okay, that is how we recognize. Oh yes, this is a case of triple endometrium. Now I can do my IUI. There is high chance of success. Her endometrium is receptive now. Just the embryo should be formed. That is the only aim. Her endometrium is receptive. Why I have told this much story to you? If I tell just this is a triple endometrium, you can see hypoechoic, later you will forget. Now you know the full concept. So whatever question they ask, they may not give the photo. When you want to do IUI, they may give this video. Do you want to do now, later, 1 week later, 1 week before? Yes, when you want to do now, because triple layer is there. So that is when we do the IUI. That is when the embryo implantation is better. Okay, so this is the reason. I hope you have understood this. Okay, very good. So now let us move ahead with the third question. Okay, this question, which of the following is correctly identifies the labeled frontanelle and its normal age of closure shown in the video? Okay, now you tell me. Okay, in the answers, X is lambda. Okay, this is X. Is this lambda? Lambda is your posterior frontanelle, isn't it? So X is lambda, directly you will cut this answer. Y is bregma. Y is lambda, correct? No. So this is Y. This is the lambda sutures. So Y is bregma. Again, you will wrong it. Y is lambda and the age of closure is 24 months. Remember, out of the two, anterior and the posterior frontanelle, which closes first? It is the posterior fontanelle. From birth to 2 months. Many babies, it is fused at birth or maximum by 2 months it will fuse. But whereas the anterior fontanelle fuses almost by 1.5 years. After 1 year, before 1.5 years. So almost around 18 months. So this is the reason why we are not choosing C as the correct answer. Okay. Then coming to the D option. X is bregma. Yes, correct. No, this X is bregma. Bregma is nothing but the anterior fontanelle, a diamond shaped. This is a triangular shaped one, lambdoid suture. So Excess bregma, this option also is correct, and age of closure is 18 months. This is also correct. So this is how you will choose your answer. Okay, so read all the options. Even if the first option is correct, if you think, still read all the options. Maybe some extra point is added in third or fourth point which is more accurate. So read all the options before you answer, before you conclude that I do not know this case. Like in our first case, you might not know in the image, isn't it? So before you conclude, read the options, try to figure out if you can do a ruling out technique. If you can rule out three options, definitely one option is correct, isn't it? So this is how you should be in your exam. For all these things, what is the key? You should be calm and composed. Don't be in a hurry, don't be tensed. Okay, this is the basic key for an exam to clear. Okay. Okay, everybody has given the correct answer. Shruti, Digvijay, everybody is given. So the anterior frontal LA, which fuses by around 18 months, that is the answer here. Okay, next question. This is a repeat question. In your recent one of your NEET exams or NICT, this question was there. How much time does the embryo typically take to travel from point 1? This is point 1. This means this is the egg that is formed. Then here is the fertilization, the sperm is come. Then is the embryo formation. Then is the two cell layer, four cell, blastocyst, and formation of the embryo and the fetus. And here you get the complete embryo or the morula, and this morula will come and go, insert and get implanted. So from here to here for implantation, it will almost take how many days? Yes, I'll wait for the answer. It is very simple answer. So let me see how many of you will tell correctly. I've got two answers. Okay, Digvijay Singh has given a correct answer and also a range of answer. Okay, both are correct. Okay. Okay, see, there is a small sort of confusion whether it is 5 or 8 is the confusion, isn't it? So you have ruled out it is not 10, it is not 2, I'm sure. So your answer is between 5 or 8, correct? No. So how will you choose now? So now you clearly see the image given. So in the image that was given in exam, it was implantation they had given, which we would have chosen as 6 or 7 or 8 days. But here it is only reaching the endometrium. Implantation happens on the 6th or 7th day post, but reaches by 5th day. Okay, it will reach by 5 to 6 days. After 7th or 8th day, it will get an implantation. So here you can choose an answer 5 because 8 becomes too late. Okay, so that is why. If it was an implantation image that they had given, implanting or implantation of the embryo, then you would have chosen 8 as the answer. Okay. Okay. Going ahead with the next question. A 26 weeks pregnant woman comes for a routine antenatal visit. On examination, symphysiofundal height measures 24 weeks. Okay, 26 weeks and it is measuring 24 weeks only. Ultrasonography shows reduced amniotic fluid. Now you have the reason for showing it as reduced or growth is less. 26 is still showing 24 weeks because the AFI around the baby is less. That is why uterus is not appropriate for the gestation. Understood? So now you will tell me which of the following condition is most likely responsible for the finding. So AFI is low. Okay, so AFI is low. Which condition will give AFI low is the question. So for this, they have given so much description. Okay, trachoesophageal fistula. So fistula means what will happen? The swallowing would not be proper. Correct? No. When there is no proper swallowing because of fistula, then it will be coming out. Everything, baby is not able to swallow. That means everything, all the fluid is in the abdominal cavity, on the amniotic sac. So it will cause mostly what? Will it cause oligo or poly? So fistulas will cause poly because baby is not able to swallow, be it duodenal atresia, esophageal atresia, or a fistula where the baby is not able to swallow properly. There the secretions are more because it is not drinking the amniotic fluid. Okay, so that is the reason it will cause polyhydramnios. Coming to the ureteric strictures. So again, ureteric strictures also can cause, but it is very rare. Okay, stricture is there, reversal of flow is there, or there is a reversal of flow, but it is not very common. Ureteric strictures, some amount of fluids will still be there. Correct? No. So it is not likely, but it can cause. Okay, then coming to renal agenesis. If there is no kidney at all, there is no urine at all, agenesis, isn't it, which will cause definitely reduced AFI. So of the answer, renal agenesis seems to be more appropriate. Then congenital cardiac anomalies. Cardiac anomalies has no much direct relation with the AFI per se, but still, of the reasons, options that they have given you, if you have to choose, renal agenesis will directly lead to reduced amniotic fluid, isn't it? So this is the answer that you have to choose. Yes, I have given, everybody has given the correct answer. Next question. A 39 weeks pregnant woman is admitted for induction of labor. The labor due to postpartum pregnancy. Sorry. Induction of labor due to post-term pregnancy. Okay, she is post-term, so you are inducing labor. Based on the procedure shown in the video, which of the following is an advantage of the procedure? So before going ahead with the advantage, what is the procedure shown in the video? Yes, first you will tell me what is the procedure shown, then we will read the options. Yes, ARM. Nitish gave the first answer, that is artificial rupture of membranes. We are rupturing the membrane so that the liquor drains, increase prostaglandin synthesis, and there will be helpful for the progression of labor. So let us say once we do ARM, what can we see? Or what is the advantage? Advantage is the question, isn't it? So can be performed in an unfavorable cervix. Okay, it can be performed definitely, but it is not an advantage. For example, if prolonged labor is there, she is not progressing, sometimes we still do in an unfavorable cervix, but usually ideal or better to do in a favorable cervix. But it is not that unfavorable cervix we cannot do, but it is no advantage. If the cervix is unfavorable, using a dinoproston gel, okay, prostaglandin E2 is better, E1 is better than a ARM. Okay, so this is the wrong answer. Allows assessment of amniotic fluid for meconium or blood. Yes, isn't it? When we rupture, we can see whether the meconium fluid is clear, whether it is having whether the amniotic fluid is clear, whether it is meconium stained, or is it having any other blood stain, dark yellow, or there is no liquor at all, or there is excessive liquor. So liquor features can be assessed, isn't it? It directly tells the condition of the baby. If it is meconium, that means baby is in distress. If it is blood, that means there is maybe IUD or there is abruption. If it is dark yellow or straw color, then it becomes what? RH negative maybe she is. There is fetal anemia. That is why it is so yellow. Okay. So if it is less oligo, if it is excess poly. So many features we can know about the baby, isn't it? So this is the correct. Let us see other questions. Eliminates the need for fetal monitoring. No, it doesn't. Even after ARM, we still have to do fetal monitoring. Sometimes when we do sudden ARM, there might be cord prolapse, isn't it? So fetal heart rate will have variable deceleration. That is why after every ARM, it is mandatory to make a note of the fetal heart rate. Okay. Then this is wrong. Then prevents all complications of labor. There is nothing that will prevent all complications of labor. Okay. Everything has to be vigilant and you have to see accordingly. Any doubts in this? So it's very simple question. So let us go ahead with the next question. A 56-year-old multiparous woman with grade 2 and 3 uterine prolapse. Okay, there is prolapse. associated with cystocele. Okay, there is cystocele. Cystocele means anterior compartment, descent also is there. So if the grade 2 or 3 means it is outside the hymen, slightly outside the hymen. Let us take this as hymen. So there is cystocele, anterior compartment. That means bladder also is out, and uterus and cervix also is out. Okay, so this is the description they have given. Let us see the question. She reports leakage of urine while coughing and sneezing. Okay, this is a different question itself. It is, I thought they are asking something about staging. Staging is by work classification best POPQ. So POPQ is pelvic organ prolapse quantification. So what is this we do? Here we will assess which part of compartment is come down, what procedure will be required. So if they give you only anterior compartment prolapse is there, you will only do anterior colporrhaphy. If only posterior, posterior colpoperineorrhaphy. If the uterus also is out, if she is elderly patient, you will do hysterectomy with anterior and posterior colporrhaphy. If she is young patient, you will do sling surgeries. Okay, this much you understood. Now let us see what is the question they've asked. Coughing and sneezing is what kind of incontinence? So what is it? Yes, it is a stress incontinence. Very good. So this becomes a stress incontinence. If somebody is while coughing, laughing, walking, climbing stairs, squatting, is suddenly losing a small bit of urine, that means it is a stress induced incontinence. The stress is what? Coughing. When you cough, the abdominal muscles will contract, and the push of the abdominal organs on the bladder is not able to hold the urine. Okay, that is the stress. So coughing, laughing, climbing, squatting, any of the position, they can have this leak. Okay, next coming to other incontinence. Which is the other one? Most important is urge incontinence. What history they would give you for an urge incontinence? It will be like, when the patient feels like voiding urine, even before she reaches the washroom or the toilet, she will void off the urine. Okay, there is urgency. Once she has the sensation of passing bladder, she cannot hold it even till she reaches a appropriate place for voiding. This is urge incontinence. Understood? And neurogenic bladder is because of some nervous injury. There is no bladder sensation at all. She cannot feel the bladder is full also. She cannot feel that urine is being drained also. Lastly, coming to overflow incontinence. This is mostly seen in post-operative patients, especially post-operative vaginal deliveries. Okay, you have put a forceps or vacuum. They can give you a history telling after a forceps delivery or after a vacuum delivery, the patient is not able to, he is continuously having leaking. Okay, that might be because of the pain. Patient is not going and voiding. So even if she voids, she is voiding very minimal. The bladder is fully full, so it is no more having any more capacity to store. That time overflow, that is, it is full, so it will cause overflow incontinence. Most common reason for this is pain, perineal pain, where patient is not able to void the urine fully, or there is some obstructive pathology because of which the urine is not being voided fully. Okay, so you've understood all the options now. So now let us go ahead and see the next question. Okay, I've read this still 7 questions. Now you will read the 8th question. A 26-year-old primary gravida at 28 weeks of gestation presents with a purulent vaginal discharge and dysuria. Microscopic examination of the cervical discharge is shown in the image. What is the drug of choice? So before you answer drug of choice, tell me what is the image shown? What is the image shown? Yes, Digvijay Singh, you're correct of the answer. Drug of choice is correct. Nitish Patel, I'll answer your question. Before I'll explain to you. Before that, let me get know what is the image shown. No, image shown. What is the microscopic organism that is shown? Why do you want to give zone or doxy or metrogyl amoxicillin? Why do you want to give any of them? What is the image shown? Neisseria gonorrhea. Yes, very good. Digvijay Singh. Yes, very good. So this is an image of the diplococci. You can see diplococci, double bacteria. It is a diplococci intracellular. Nothing but your Neisseria gonorrhea, isn't it? So diplococci intracellular. So you know what is the diagnosis? What purulent vaginal discharge and dysuria, and she is having a screening for discharge, which is given an image of the diplococci, the intracellular diplococci, which is nothing but a Neisseria gonorrhea, and the treatment of choice for that is ceftriaxone. Okay, so had it been a clue cells, had it been a vaginal discharge, where now they have given you like this cells with margins, like this clue cells they have given you, let us take. Okay, so in this, what will you choose? Clue cells, bacterial vaginosis. Had they given you bacterial vaginosis, clue cells were seen, or that mentioned you pH is acidic, not acidic, pH is high, that is more than 4.5 pHs, and their clue cells are seen, KOH test is positive, or WIF test is positive, and also they have told you the vaginal discharges, serosanguinous vaginal discharge is there. That time what will be your diagnosis? Bacterial vaginosis, correct? No, so clue cells are seen in bacterial vaginosis. So that time what we will choose? Metronidazole. Yes, very good. Had they given you clue cells, you would have chosen metronidazole. Now coming to Nitish's answer and Shruti's answer of B. Doxycycline. Is doxycycline safe in pregnancy? I have told you she's primigravida with 28 weeks of pregnancy. I am understanding that you have written doxy thinking she's a gynec patient. Okay, doxymetrozole we give for PID in a gynec patient. Doxycycline is contraindicated in pregnancy. It cannot be given in pregnancy, isn't it? So that is why we do not use doxycycline in pregnancy. That is why you cannot choose option B. Understood? Okay, now let us go ahead with the next question. The video depicts a term primigravida during labor. Based on the stage demonstrated, which of the following is the principal physiological event occurring at this stage? Okay, so before going ahead with the question answer, tell me what stage of labor they have shown in the image or the video. What is the stage of labor? Okay, we'll answer that later question. But the question I've asked is which stage of labor is there have been showing in the image? Yes, everybody is correct. I think all of you got out of 32 questions, everything correct, is it? Everybody is answering me very correctly. Yes, they are showing the first stage of labor. First stage is nothing but from the onset of true labor pains. Okay, you should remember true labor pains till full dilatation of cervix. So that is what they are showing. They are showing the dilatation and effacement, isn't it? So when you know this answer, you can easily choose the answer given in the option. So you will not be able to get confused by the options that they have given. Descent and expulsion happens in what stage? It happens in second stage, that is mechanism of labor. For this, physiological changes has to happen, isn't it? So they are showing you the cervical dilatation. Is it descent and expulsion of fetus? No, fetus is still inside the uterus. There is not much descent that they are showing. What they are showing is the cervical dilatation and effacement. Separation of delivery of the placenta. Baby is still here. How can placenta be delivered? Again, you can rule out this very easily. Next, coming to the uterine contraction mediated postpartum hemorrhage. So for that postpartum should happen. No, baby is still inside. It is intrapartum that we are seeing. It is not postpartum. So these are very easy questions. Okay, image and video based are very easy. So not just one clue in the question they are giving you. They are giving you clues in the question. They are giving you clues in the video. They are giving you clues in the picture. So you can easily choose your answer. Okay, so that is why the C answer will be wrong. Then cervical effacement and progressive cervical dilatation. Yes, this is what they are shown in the video. Okay. Why Shruti and Samina are saying it as A? Is it descent and expulsion? Can you see the baby coming down till the internal os, external os at least? No, no, baby is still in its own position. Okay, it is trying to get engaged. There is no descent here. Baby should come down for descent. When your video has, the baby has hardly moved for a 0.5 cent, not even 0.5 centimeters, I think. But the cervix is dilated so much, isn't it? So this is one more reason you should see the full options. Okay, don't jump into your conclusion by seeing the first answer. Okay, next question. A pregnant woman previously infected with hepatitis B virus becomes anti-HBe positive during follow-up. This is most likely indicates. Okay, this you have read in medicine, surgery, pathology, everywhere, isn't it? Hepatitis B and its antigen antibody is very important. So HBs is there, antigen, that means it is infective. Okay, HB is antibody, immune. Now they have given you HBe positive antibodies. Okay, so they have given you virus becomes anti-HBe positive. So that means that she is already become immune to the HBe part of the virus. So that means the infection is reducing, isn't it? Anti-HBe is positive. So it is not HBe antigen positive. Had they given you HBe antigen positive, that means she is acute infection or severe infection. Okay. Okay. See, that is what I told you. Harini Dharan. So had they given you only HBe antigen positive, then she becomes infective. Now she is anti-HBe antibody positive. Okay. So that makes her immune to the HBs virus and she becomes less infective. Decreased viral replication is happening. Okay. Understood? Yes, very good. So decreased viral replication is the answer. Okay, this image moves so fast. Oh my goodness. I don't know how you guys answered this in exam. Yes, Shruti, correct. Your B answer is correct. It has come 3 times. Okay. Now, a 29-year-old primary gravida with rheumatic heart disease presents in active labor, which is preferred maternal position during the first stage of labor to reduce the cardiovascular complication. Okay, now you have to know this is a cardiac patient, heart disease patient, and she's in what stage of labor. Okay, before concluding into this position, I want to put her what stage of labor. She is in first stage of labor. So first stage of labor, first of all, patient need not be bedridden. You can ask her to ambulate. Gentle ambulation is okay. Okay. And now to reduce the cardiovascular compromise, which is the correct position? A is what? Okay, let me try and pause if I can pause this video. Okay, A is when the patient is completely lying down. Okay, I'm not able to pause it. Okay, let us think. A is patient completely in supine position. B is when the foot end is raised. C is left lateral. And D is in a dorsal, I mean, lithotomy position. Okay, so I'll just give you. A is supine. B is foot end raised. C is left lateral. And D is lithotomy. Okay. Digvijay Singh, you answered me before I write this, or you answered me later. Now you can, if you want, you can choose your another option also. Or footing raised. Okay. I've got 2, 3 correct answers, but still I'll explain it to you. See, in first stage of labor, patient is mildly ambulatory. She has heart disease, no need to be bedridden. But instead of lying supine or foot end raised any position for heart disease patient, need not be in labor also, in third trimester also. Which position you will advise her? You will advise her left lateral position, isn't it? So position C is the correct answer. Only in second stage of labor, when she is pushing, instead of giving lithotomy position, you will give the head end raised. It is head end to be raised, not the foot end. So in this, none of the options are correct, even if she is in second stage of labor. Left lateral is in the first stage of labor, head end raised in your second stage of labor. Understood? She cannot be supine, more chance of hypotension, decreased blood flow to the heart, and then if a foot end raised cannot be done, increased preload on the heart, and lithotomy position is not preferred. You will like to give a head end raise. This is in plus head end raise should be done in case of a second stage of labor. In first stage, you can ask her to lie down left laterally, okay, or ambulate mild. Okay, this is about the next that question. This image is making me go crazy. It is moving so fast. Okay, so we'll go ahead with the next question. A 37-year-old woman who has had two children reports that her periods have been stopped for past year. Okay, she is 37 years. Normally menstruation or ceases by what age? 45 to 55 years. Okay, in India more common between 46 to 48 years. In developed countries it is, or like in UK, it is 51 years. Okay, in Indian women we tend to attain menopause by 45 to 46 years. Okay, 46 to 48 is the peak time in India, 51 years in developed countries like UK. So now this woman is not attained menopause for menstruation for 2 years. Okay, at the age of 37 itself. Okay, she is just 37 and she is not menstruating. Okay, no menstruation. Reports that her periods have been stopped for past year, and lab test showed elevated FSH. Okay, FSH is very high, LH is again high, along with AMH is very low, 0.05. Okay. Yes, what is your diagnosis? Digvijay Singh, very good. You give the first answer. As I described you in the initially only, postmenopausal or AMH should be low and FSH is LH is both are high. That means her ovarian reserve is not there anymore. This should happen postmenopausal, that is at the age of 45 and plus. It is happening very early to her at the age of almost 37. She still had 8 to 9 years minimum for menstruation. Okay, so this many years she is not menstruating means this many years of bone loss, less collagen, less activity on the heart. So a lot of complications would happen to her. So this condition is called as premature ovarian failure. Okay, premature ovarian insufficiency. So this is the correct answer. Coming to PCOS, even in PCOS, FSH may be raised, you can ask me. But remember, in PCOS, AMH is low or high? Yes, in PCOS, is AMH low or high? Yes, fast. What happens for the AMH levels in PCOS or PMOS? Low. Okay, so in PCOS it is reverse. Okay, Digvijay saying it is high. Okay, AMH, because so many cysts are there. So this AMH or anti-Mullerian hormone is nothing but the hormone secreted by the preantral follicles. So in PCOS there are so many preantral small follicles peripherally arranged, isn't it? So many preantral follicles are there. So AMH would be very high in case of PCOS. It is not low. Okay, since it is low in this case, it cannot be PCOS. Okay. Okay. Shall we go ahead with the next question? Yes, AMH is high. Very good. Correct. Which of the, okay, Harini told AMH is high, but still she chose PCOS. So this is what I'm trying to tell you. So remember, it is not about what you know. It is how you apply your knowledge. That is why they give you a clinical case-based scenario. Had I given you directly all the values and tell me what it is, I'm sure everybody would have answered correct. isn't it? So since I am giving a clinical case based scenario, it is very difficult. Okay, this page, this age I have to take important, here I have to take the values important, then I have to take her complaints important. So you should know how you assess completely all of them, from age, her complaints, her lab reports, her scan reports, everything has to be assessed before you conclude for a clinical based scenario question answer. Okay, yes, very good. Next, coming to which of the following device is commonly used for uterine balloon tamponade in atonic PPH? Okay, yesterday I had shown you this image. This is a what image? Bakri balloon image, and this is a Sengstaken tube. Okay, this is used for a esophageal inflation. This tube also can be used in an emergency. Yes, this, and Foley's catheter also can be used to inflate inside the uterine cavity and distend it. So all of them can be used for PPH as a balloon or a mechanical method of prevention for PPH. Okay, so the correct answer is all. Very good. Again, Digvijay Singh is giving me all answer correct. How much did you get, Digvijay Singh, in your mock test? All correct? Very good. I am very much impressed. Okay. Next question. Uh, the image below shows the layers of vaginal squamous epithelium A to D. Okay, A is superficial, intermediate, parabasal, and basal layers. Okay, during pregnancy, vaginal smear cytology predominantly demonstrates cells derived from which labeled area? A, B, C, D. Yes, D. Is this for this answer? Yes, 13th answer you're saying, I think, Shruti. So for the 14th question, your answering is not all. Mm-hmm. Come on, hurry up. Okay. So you didn't understand the question, I believe then. So in pregnancy, what is the hormone? It is progesterone. Correct? No. So progesterone basically, yes, very good. Nilesh Narayan gave the correct answer. Shruti also gave. Yes. So the correct answer is progesterone which will act mostly on the intermediate layers. Okay, the more number of intermediate layer of cells are seen because of progesterone in a case of a pregnancy. If you take a vaginal cytology, that's why we usually do not do pap smear also in pregnancy. We do postpartum or before pregnancy or in the early trimesters. Okay, next question. In a twin pregnancy without any additional obstetric complications, the fetal part presentations are shown in image A and B. What is the preferred mode of delivery of twin A and twin B? Okay, this is twin A and this is twin B, not like this A and B. So, twin A, first image, how will you deliver? Second image, how will you deliver? Respectively, in each scenario. Please forgive for this image. There is membrane. Okay, both are amniotic. Okay, in monoamniotic, we don't give a trial only of vaginal delivery. If it is a monoamniotic, monochorionic, monoamniotic, it is direct indication for LSCS. Okay, there is no question of having any other choice. Now in this scenario, which one? First one image, how would you deliver? Second one image, how would you deliver? They are diamniotic. There are two different gestational sacs here. Okay, Nitish Patel has given answer both vaginally. Is it? Is it for this question? I don't think so. I think he has answered for the whole question. Okay. Yes, so Nitish has given the correct answer. Even Digvijay and Shruti, everybody has given the correct answer. Very good. So whenever there is breech as the first twin, which first twin has having breech other than cephalic, only when the first twin is cephalic, we will give a trial of vaginal delivery. Otherwise, we do not give a trial of vaginal delivery. Understood? Only when the first twin is cephalic. Okay, remember twin one is cephalic, then only vaginal delivery trial will be there. And there is no vaginal delivery trial in monochorionic monoamniotic. Okay, understand this much. So correct answer will be, since first one is in breech, so first one is by cesarean. Here first one is cephalic, so it is by vaginal delivery. C, correct. Okay, next question. A 30 weeks pregnant woman presents with irregular uterine contractions and cervical changes. The obstetrician plans to delay delivery to allow administration of corticosteroids. Which of the following is drugs will not be useful in this case? Okay. Delay. How for a preterm labor, to prevent preterm labor, what are the medications you want to give? So no, what medication you do not want to give, cannot prevent preterm is the question. Okay, first is nifedipine. Is nifedipine a drug of choice or the important drug for preterm labor? Yes, it is. Okay, it is a calcium channel blocker. It will reduce the myometrial contraction. So nifedipine is the drug of choice or very good action, especially in threatened preterms or early preterm labors, unless until you want to buy time till the steroids act or your magnesium sulfate acts. Okay, nifedipine can be given. Okay, this is the correct answer. Next comes your progesterone. Progesterone, is it useful later gestations of pregnancy? Very unlikely. Progesterone is useful only till 20 weeks. Okay, before that, before 20 weeks, if let us say threatened abortion is there, we can use progesterone, not for threatened preterm labor. Understood? If it is abortion or a miscarriage, threatened miscarriage, not a miscarriage per se, a threatened miscarriage, they have given a description, then you will use progesterone, not for a threatened preterm labor. Understood? Atosiban. What is atosiban? It is a antioxytocin, so or the syntocin, so this can be used, it will reduce the contractions. Indomethacin for pain, it can be used. Okay. Okay, so indomethacin is used for pain. It is not as such used in general, but if for pain we can give NSAID, that is nothing but indomethacin, isn't it? So that is, this is why we can give. But progesterone is usually not preferred to prevent preterm labors. Okay, so next. The gross specimen shown in the image is obtained from a 19-year-old female with an ovarian malignant germ cell tumor. Which of the following female counterpart of seminoma? Okay, just like how we have testicular tumors, we have ovarian tumors. In testicular tumors, it is seminoma, means in ovarian tumor, it is dysgerminoma, the early germinal cells. So it is a dysgerminoma. So the correct answer here is D. Okay, so yolk sac tumor in male also it is yolk sac tumor, choriocarcinoma in male also it is choriocarcinoma, and as endodermal tumor is again endodermal sinus tumors there also. Only your dysgerminomas are your seminomas. Okay. Yes, correct answer. Next question. During routine antenatal examination, a 34 weeks of gestation, the symphysiofundal height measures around 29 centimeters. Okay. For a 34 weeks patient, can the symphysiofundal height be just 29 centimeters? So it is so much difference, isn't it? It should have been 34 centimeters. It is just 29. Almost a difference of 5 centimeter is there. Okay. The fetal lion presentations are normal. Liquor appears clinically reduced. Which of the following is most likely interpretation? Normal variation of symphysiofundal height is plus or minus 2 centimeters. Yes. So normally it should be that. Is our patient normal variation? Is our patient having just plus or minus 2 centimeters? She almost have 34 and 29, 5 centimeters of variation, isn't it? So this is not seen in our patient. Suggestive of fetal growth restriction. Yes. IUGR is there. It might be a small baby. That is the reason it is having a case. This is a symphysiofundal height could not grow, or the uterus is not grown just because the baby is not grown. Here the liquor also is reduced. In FGR there is oligohydramnios very commonly. Okay. Then suggestive of polyhydramnios. Liquor is clinically reduced. So clearly they have given this. You will directly rule out, isn't it? Due to the engagement of fetal head. When does the fetal head get engaged in primi and multi? Yes. You answer me this now. When does the fetal head get engaged in primary and multi? Yes, answer everybody is given me correct as B. But when does this fetal head get engaged? Is this reduction of centimeters because of fetal head is engaged? Primary, multi 37. 37 weeks. Yes, okay. I think Digvijay Singh's answer is come in two slides. Nitish also is given an answer, but I'm not understanding what exactly he's mentioning. I'll just wait for 10 more seconds, then I'll explain to you. Okay, fine. See, in primary, it is usually engaged after 36 weeks. By the age of 38 weeks, head should get engaged. Our patient is just 34 weeks. We do not expect head to be engaged by now. Understood? So after 36 weeks and before by 38 weeks, it should get engaged in primary. Whereas in multi, it can get engaged early, but usually it engages in labor. With the onset of labor, labor onset, the head is going to get engaged. Understood? So in multi, it is not going to get engaged in the antenatal period, whereas in case of primary, it will start by 36 and by 38 weeks, head should be engaged. For a primary patient, if the head is not engaged even by 38 weeks, then you should rule out cephalopelvic disproportion. Okay. Next question. A 50-year-old woman with suspected genuine stress incontinence. Okay, stress means what? One more question was there. I have told you. Undergoes evaluation. Which investigation demonstrates bladder neck funneling? Okay, so cystourethropy, you only see the inside one. So bladder neck funneling cannot be seen. Same with uroflowmetry, you will only measure the pressures. You cannot see the funneling. And cystometry, again you only measure the pressures, you cannot see the funneling. Video cystography, when we are taking a video along with that, when there is a pressure, what is happening with the bladder neck, that is video cystography will tell you the exactly what is happening with the bladder neck. This will become the gold standard for diagnosis of the bladder neck that time. Okay. Next question. RH negative women at 32 weeks of gestation with an anti-D antibody level of 18 international units. Okay. More than 1 is to 4 is there, then you should start evaluating. More than 1 is to 16 is there, that means she is crossed the critical value. That means very high chance of developing fetal anemia. Understood? For after 1 is to 14, you should do further evaluation. Keep on evaluating the patient. Okay. What finding on middle cerebral artery Doppler is more suggestive of a fetal anemia? In one of the class, antenatal class, last 2 days, I have explained this value also. So let me see who was attentive in class and is answering this question. After we got this middle cerebral artery PSV, which becomes the non-invasive method of diagnosing fetal anemia. So when I was telling about amniotic fluid odds ratio, which was initially used for diagnosing fetal anemia using the amniotic fluid. So that time I was telling you color was yellow color, and that time we used to use the invasive methods for fetal anemia. But right now we do not use invasive methods at all for fetal anemia, because this middle cerebral artery PSV is very accurate and it will tell until 36 weeks you can use. Okay. Yes, very good. I've got few correct answers. That is middle cerebral artery PSV of more than 1.5 multiples of median. This is the correct answer. Very good. Next question. A 32-year-old primigravida with history of chronic hypertension presents at 36 weeks of gestation with headache, blurring of vision. Her blood pressure is 170 by 110 mm of Hg and urine dipstick shows 3 plus proteinuria. Okay, so what is your diagnosis with this? First, before going ahead with the next step, what is your diagnosis here? Yes, tell me the diagnosis fast. Okay, answer is correct, Digvijay Singh. But what is your diagnosis? Preeclampsia. Okay, I will give you the options now. So for your diagnosis, I have given you answer. A is preeclampsia, B is severe preeclampsia, C is severe preeclampsia with imminent eclampsia, and D is gestational hypertension. Now you tell me what is the answer. Okay, Nilesh had given the correct answer in nearly correct answer. So now you should tell me ABC. What is your answer? This is A, this is B, this is C, and this is D. Okay. Give me as A, B, C, D. Don't mention now severe and all. Okay, first I expected this answer, but you just gave me as C. I mean, just gave me as preeclampsia. Shruti, do you want to change your answer? Keep it the same. Is it a typo? Okay, it is a typo. Now I've got the same answer multiple times from your end. Okay, so in this patient, we have very high blood pressure, which is almost a severe category, isn't it? So why did you write in the first go as simple preeclampsia, preeclampsia, preeclampsia? So first only you should be very clear in your thoughts. So it is a case of severe hypertension, isn't it? Whereas 3 plus proteinuria also is there. Along with that, she is having imminent signs. Headache, blurring of vision is there. So if you do, I have told you in class also, if you do not give her magnesium sulfate right now, in next any time soon she can throw seizures right in front of you, isn't it? So that is why it becomes really very important. Understood? So start administering the magnesium sulfate and plan the immediate delivery. So the correct option would be magnesium sulfate with antihypertensives like lebetalol, IV lebetalol, and then plan delivery at the earliest. This would have been the correct answer. Understood? So here in of the given options, administer magnesium sulfate and planned delivery would be the best. Giving oral lebetalol would not be of any use for such a high BP with imminent features. Admit and monitor the blood pressure for 48 hours would be the worst option. Start methyl dopa, okay, antihypertensive, and perform urine routine after protein 24-hour urine protein. No, methyl dopa is also not a case of not a drug of choice for acute or severe hypertension, isn't it? That time we have to manage the acute crisis. So the correct answer is only B. Rest all I'm sure you would have not answered, but still you should know your diagnosis. Had they given you next time what is your diagnosis? Isn't it? Answer for 21 is B for sure. But what I'd asked for diagnosis, they have answered it as C. Okay, you Raj, they have not answered the correct answer as B. Okay, coming to the next question. A 48-year-old woman presents with postcoital bleeding and foul smelling discharge. On pelvic examination, a 2.8 centimeter cervical growth is seen. Okay, so this was just our yesterday's class. I explained you so much yesterday, so I'm sure you will answer this very correctly now. Okay, postcoital bleeding, first you should think of CS cervix, correct? No? So then you do pelvic examination, you saw a growth. It is 2.8 centimeters of cervical growth. extending to the upper third of the vagina. Okay, now let us take this as the cervix and this as the vagina. Growth is there, 2.8 centimeters, cervix and vagina. Okay, 2.8 centimeters. Okay, without parametrial involvement. So there is no parametrial involvement. And MRI confirms these findings with no evidence of distant metastasis. No lymph node. Okay, no lymph node metastasis. And sidewall involvement. According to FIGO, what is the staging? Okay, let me see what all answers you have given me. Nitish has asked me what to do if persistent hypertension after 3 doses of labetalol. So in our class, we thought, Nitish, we start with 20 mg IV labetalol, then 40, then 80, then 80. Okay, this much you can go directly. But then if it is still not controlled, then you will go for hydralazine drip. Okay, hydralazine drip would be your next choice. Or GTN patches and drips also can be started. Yes, the correct answer is 2A1. So this answer is correct. Very good. Hemant Kumar is answered as 2B. Okay, 2B is extension into the parametrium. Okay, so it is not extension only to the upper two-third. Upper two-third extension is nothing but your 2A1, whereas if it is parametrium involvement, it is 2B. Upper two-third less than 4 centimeters, more than 4 centimeters. Okay, A1. Understood? So next question. A 28-year-old pregnant woman at 18 weeks has HB of 9 grams. Okay. And middle cerebral artery, sorry. Let me read it from first again. A 28-year-old pregnant woman at 18 weeks has HB of 9 grams and the mean corpuscular volume was 75. Okay, coliters. And then serum iron studies are normal. Okay, so this is low, the MCV is low and your HB is low. HB is low, MCV is low. Microcytic hypochromic. Microcytic hypochromic anemia. Okay. Microcytic hypochromic. So now microcytic hypochromic means what is your first diagnosis? Whenever there is a blood picture smear saying it as a microcytic hypochromic, what comes to your first in your mind is iron deficiency anemia, isn't it? Iron deficiency has microcytic hypochromic picture. But here they are saying serum iron studies are normal. Which of the following investigation should which of the following investigation shown in the image is the next best test? Choose the correct investigation from the images below. So what is this image? What they're doing in the first image? Okay, you tell me. Everybody is answering beta thalassemia. Yes. So your second most important diagnosis for microcytic hypochromic is what? Thalassemia traits. Okay, especially the beta thalassemia traits. Okay, that becomes your second most important diagnosis for microcytic hypochromic when the iron studies are normal. If iron studies were not mentioned, what is your primary diagnosis? Then you should always tell as first is iron deficiency anemia. So you should always ask for iron studies. If iron studies are normal, then only you will go for further testing. So what is the image shown in the first one? Yes, Digvijay Singh is given. Correct answer. Nitish Patel also is given. So HB electrophoresis is the first image. What is your second image? Yes, what is your second image and third image? That also you tell of. This is second image. This is third image. B and C. They're showing in second image. IDA means iron deficiency anemia. Very good, Nilesh Narayan. You've given the correct answer. So I'll wait for somebody else to also answer, or shall I go ahead? Yes. So everybody is giving now the bone marrow biopsy. So here we are suspecting thalassemia. So we are doing HB electrophoresis. Had they given HB is low, platelets are low, WBCs are low, it looks like aplastic anemia. So that time you'll have to do bone marrow biopsy. Why nothing is getting synthesized? Is there some problem with the bone marrow? Isn't it? So that time you would do bone marrow biopsy. Okay. So this is the second image. Very good. And what is the third image? Okay, let me see who gives the correct answer for third image. What is the image shown? Yes, correct answer is A. So I am not just aiming at telling the correct answer for this. I am giving you so many questions from one individual questions. By just doing this question, you will be able to at least answer at least 3 4 questions from any other different related topics if they ask also. That is the main aim. That is why I am taking so much time for in every questions. Liquid chromatography. Okay. So it is this third image is as simple as a Coombs test. Okay, they are doing a dilution. With every dilution, where exactly there is a hemorrhage. Like for example, for a fetomaternal hemorrhage, when we do what we do, a mother's indirect Coombs test, isn't it? So that is what we are seeing in this image. This is nothing related like that. Okay, this is a Coombs test, indirect Coombs test for the mother. If it is the baby's blood, then it is direct Coombs test. Okay, this is how it is shown. Okay. Okay, next. Next question. A 32-year-old woman with ruptured tubal ectopic pregnancy is hemodynamically stable and managed at a tertiary center with an advanced expertise. Best surgical approach is what? Okay, ruptured tubal ectopic is there. There is a rupture tubal ectopic. So, for an ectopic pregnancy, we have three managements. One is expectant management, one is medical management, one is surgical management. So for whom you will choose, what is the question? Okay, so expectant management, when beta hcg is less than 1000, hemodynamically stable, gestational sac is very small, and there is no cardiac activity. Okay, and for medical management, what do we give for medical management? Methotrexate. Okay, methotrexate is given for medical management. In methotrexate, for to give methotrexate, what are the important things? Beta hcg ideally should be less than 1500, until 3000 also you can take it. Okay, you can still give. And gestational sac should be less than 3.5 centimeters, and there is no cardiac activity, and for most important is patient should be stable. Okay, no cardiac activity and patients should be stable. Whereas surgical management, for whom we do, whenever the size of the cyst is big or the ectopic is big, more than 3.5, hcg values are more, patient is unstable, it is a ruptured ectopic, even the size is very small, let us take it as 3 centimeters cyst, but it is ruptured, means you have to do it, isn't it? You cannot let the bleeding keep happening inside the peritoneal cavity. So that time you will have to take. So in surgical, again we have two things. Okay, one is laparotomy and one is laparoscopy. So laparoscopy is when patient is stable. If it is ruptured, patient is definitely not stable. You will have to do laparotomy, exploratory laparotomy. But if it is a stable patient, if they have given you beta hcg is 5000, but she is a stable patient and cardiac activity is there, ectopic pregnancy, that time what you will choose? Laparoscopy. Has they given you an option that it is a ruptured ectopic, you should always choose an option of laparotomy. Okay, mandatory laparotomy. Okay, a very good correct answer. Expectant management you cannot do for a ruptured ectopic. And salpingostomy. So salpin in laparotomy and laparoscopy we have another two options now. Either you can remove the entire tube, or you can just make a hole and remove the ectopic and leave it open like that. Okay, to save the tube. Okay, maybe she had one more ectopic, the other tube was open and it is not there anymore, so she has only one tube, so she has to conceive with that only, isn't it? that time we will conserve the tube, but there is no guarantee that the tube would be efficiently working, but still we will conserve that tube. Okay, whatever efforts we can do, we will do. So that is the main aim. So salpingostomy can be done when it is unruptured, not when it is ruptured. It is already given when it is boring. You should clamp and remove the tube fully. You cannot do this. Laparoscopy for again for a stable patient. Okay, now before going ahead, I'll give you one more scenario. You will tell me the answer, which among this you will choose. Okay, so here is a patient. She walks to you with a scan report. Okay, tubal ectopic is there and it is around 3 centimeters. Beta HCG is 2500. She is stable. Okay, patient is walked to with you. So she is stable patient. Beta HCG is 2500 and cardiac activity is there. So what is the treatment of choice? What amongst this, which one would you choose? Given options, which one would you choose? So for this question, you answer me. Stable patient, tube scan says tubal ectopic with 3 centimeters gestational sac, 2500 beta HCG and cardiac activity is seen. Expectant management, is it for this answer, is it? Medical management, expectant management. Mm-hmm. Okay, when I told you the criteria for choosing, I clearly mentioned cardiac activity should not be there, isn't it? If there is cardiac activity, the sac will grow very fast. So cardiac activity should not be there. Understood? For you to do medical expectant management, cardiac activity should not be there. Now you give me the answer. Yes, Digvijay Singh has given the correct answer. So when I mentioned the criteria to choose, a stable patient, beta HCG less than 3000, SAC less than 3.5 centimeters and cardiac activity should be negative, I told you. Now I gave you cardiac activity is present. Why are you choosing medical management, expectant management? Salfingo? Fast. Only two answers? So what you would do here is laparoscopy and proceed. You will put the laparoscope and try to see whether you can save the tube. You have to remove full tube based on that. First, what you should do is your laparoscopy for this patient. Had they given you that previous history that she is gravida 2, ectopic 1, or salpingectomy is right, salpingectomy is done. Now it is left ectopic pregnancy. That time you would choose salpingostomy over salpingectomy. Okay, for salpingostomy, it should be previously operated. The other tube is not good, or she is not having any kids till now with no previous one more side tube, and you want to save the tube where the tube is not yet ruptured. Only then you can do salpingostomy. Okay, it is not ideal procedure what we do. For a few selected patients only, we do that procedure. Next question. A woman who is 37 weeks pregnant with her first child reports that she hasn't felt her baby move as much as her past day. Okay, so decreased DFMC is there. A non-stress test shows one acceleration and fetal heart rate over 20 minutes. Okay, so 20 minutes of NST has only one acceleration. At least two should be there, isn't it? So with no deceleration, what should be the healthcare providers do next? Okay, what do you want to do next? What do you want to do next? Continue monitoring for next 40 minutes or start the process of induction of labor just because she has decreased DFMC and there is only one acceleration. Do you want to induce her? No, okay, I've got so many correct answers. So this you are all very clear with this concept. That means perform an operative vaginal delivery. She's not yet even in her early stage of labor. Why are you talking about second stage of labor? No. Proceed with an emergency cesarean section. No. You will proceed for another 40 minutes of NST. Wait until you get at least two accelerations. If you get or don't get, still you will do a scan for this patient. I had explained to you this in a class, isn't it? So the correct answer is A. Next question. That was also a repeat question. This is also a repeat question. What can you see? A frog's eye appearance. Even before seeing the question, I'm sure you will answer this question without even seeing the full question history. A pregnant woman at 23 weeks of gestation presents for a routine anomaly scan. Ultrasound image shown below demonstrate a characteristic fetal cranial abnormality. Cranial abnormality. So much they have given you. So if you do not know the image, at least read the question. It will strike you. Answer will strike. Just be calm and read. One of them will give you a clue to answer. Okay. Fetal cranial abnormality, which of the following congenital anomaly is most likely associated in this ultrasound finding? Yes, Digvijay Singh, biophysical profile, absolutely correct for the previous question. Yes, after that, BPP was not there in the option either. Even before going to BPP, you should continue for another 40 minutes at least, for total of 40 minutes at least NST to be done. You will get the 2 acceleration. Why? Because fetal sleep cycle would be maximum of 30-40 minutes. That is why. Okay. B. Anencephaly. The frog's eye appearance, absent of cranial vault, everything is seen in this image very clearly. So I'm sure you will answer this as anencephaly. But remember, it is if they had given you the same patient, they didn't ask you the diagnosis. This was seen in the scan. The same patient, she is at 25 weeks. What would you advise her? Since she's crossed the period for 24 weeks is the cutoff, isn't it? What would you advise her? For 25 weeker, what would you advise her? MTP termination or continuation of pregnancy as she has crossed the period of viability? I mean, the baby has become viable, or you want to, let us say, conservative management you want to do, or you want to, without informing, do the procedure. I mean, do the delivery without doing any consent forms. What do you want to do? The same patient they have given you now, but they didn't ask you what is your diagnosis. They have asked you what is your management, but not at 23 weeks. Let us keep it as 25 weeks. So I'm sure before 24 weeks, everybody will answer me correct. MTP, MTP, MTP. Now she's become 25 weeks. So options I will give you. One is MTP. 2 is MTP plus, so easy it will become if I give medical advisory board. Medical advisory board. 3 would be your continuation of pregnancy. 4 would be just terminate, no need to inform anyone. Yes, MTP has no limit for the congenital anomaly for the upper limit. Okay, but you should create a medical board. Everybody should tell, yes, this baby has no survival, with a scan, obstetrician, pediatrician, and a lawyer. All of them would advise, yes, this all things will be there. So you will be able to continue with the MTP procedure. Understood? Yes, it is not just MTP with a medical advisory board since she's crossed the period of viability. Okay, if it was before 24 weeks, just two doctors consent, you do the MTP, no problem. If it is after 24 weeks, take a medical advisory board. Okay, can you do termination? Okay, if the same, some other question I'm asking you, termination of pregnancy. A lady comes to you, she is 23 weeks now. She will tell, I already have 2 children, I do not want this pregnancy. This is a pregnancy due to failure of contraception. Can you do MTP for her? She is 23 weeks now, and failure of contraception is her indication for termination of pregnancy. She wants to terminate the pregnancy because this pregnancy was due to failure of contraception. No, yes. Why? Because For failure of contraception, even till date, the termination can be done only till 20 weeks. The other indications they've increased the upper limit to 24 weeks. After 24 weeks, it is a medical advisory board. But for failure of contraception, till date, it is only 20 weeks only. You cannot do it after that. Okay. Yes. Next question. So what is shown in this image? Again, this image so many times they have asked you. So I am very sure you people know all these things. So this is the angle that you should see. If this angle is acute, then it is a septate uterus. Okay, septate uterus. If this angle is obtuse, okay, if it is more than 115 degrees, then it is a bicornuate uterus. If there are two separate uterus they have given you, then it is a uterine didelphys. Okay, as simple as that. And yes, till 20 weeks only. Very good. No, I'm not telling about anencephaly, dear. I told it is normal pregnancy. She is telling I don't want pregnancy because this pregnancy was a contraception failure. If there is anomaly, the indication itself changes, isn't it? The termination is for anomaly, not for this one. Correct. So the correct answer here is septate uterus. The angle is acute. Had the angle been obtuse, you will use the biconjugate uterus. Has they given you two separate uterus, then you will choose an option of a didelphys. In arcuate, very small indentation you can see. You won't see such a huge gap. Okay. Now coming to the forceps. I had shown you this forceps very clearly. What is the name of the forceps? Where do we use it? First, who will tell me the name of the forceps? Hmm. Keelan's, very good. Digvijay Singh gave the first correct answer. Yes, this is a Keelan's forceps and it is used for mid pelvis forceps. This is a rotational forceps. Okay, really requires a good obstetric skill to apply this forceps. Usually, what we use is an outlet forceps, which is small. That is our Wrigley's forceps. This is a bigger one. You can remember like that, a bigger one. So it will go till the mid pelvis. So mid pelvis, why we are putting, we want a rotation till to happen. Since the rotation is not happen, delivery would be difficult. So rotational forceps. Yes, the correct answer is C. Correct. So this is a Killen's forceps and outlet forceps. No, this is wrong. Mid forceps for occipito anterior position without rotation. So it is not occipito anterior. Once it becomes occipito anterior, that means the rotation is completed. So you cannot tell without rotation. So this is wrong answer. Rotational forceps delivery with deep transfer arrest and asynchronism of the head. Okay. So that is the most important indication to apply this. Where there is asynchronism, where the rotation is not completed, and a mid pelvis forceps. Okay. Trial of forceps with fetus with extended head face presentation. No, at the level of ischial spines. At the level of ischial spines will become a high forceps, which is not used anymore in modern obstetrics. So is at the level of ischial spines is level 0, isn't it? Above that minus 1 2 3, below that is plus 1 2 3, like that. So at the level of ischial spines becomes the high forceps, not the mid cavity forceps. Understood? Okay, next question. Oh my goodness, again this video is moving so fast. Okay, a 42-year-old woman, okay, let us say this video we are not understanding. How will we see answer from this question? A 42-year-old woman who is multiparous, presents with a chronic pelvic discomfort, intermittent lower abdominal pain for 1 year. Diagnostic laparoscopy video and post-operative uterine specimen is provided. So they have done hysterectomy. So as they have told, uterine specimen is provided. Based on the clinical presentation and the operative findings, what is the most likely diagnosis? Yes, 42 years, we can have endometriosis which will cause pain. Polyp would not cause pain. Adenomyosis will cause pain. Fibroid is also not much painful. Okay, so mostly the diagnosis between endometriosis and adenomyosis. Now seeing this video, though I could not see anything. It is moving very fast for me. I hope it was not like this for you in the exam. Mm-hmm. Yes, in this image we can see clearly this is the adenomyoma. Okay, there is no whirlpool sign or there is no whirl like appearance of the smooth muscle fibers in like have we see in fibroids. So this is not a fibroid. This is a adenoma. So fibroid is not there. Endometriosis is not there. So correct answer will become your adenomyosis. So by ruling out, we ruled out two options because of pain. By seeing at the image, we saw this not endometriosis, it is a adenomyosis. So correct answer will be adenomyosis. Okay. Yes, everybody is correct. Next question. A pregnant woman in her first trimester recently returned from Zika endemic region and developed mild fever, okay, rashes and conjunctivitis and joint pain. If her fetus acquires congenital Zika infection, which of the following is most characteristics? Okay, for Zika, you remember, Zika is not common in India. It is only when somebody is traveled to South Africa and African countries and come. So if it is infected or if somebody is gone and travel and come, most commonly it will cause microcephaly. Okay, microcephaly. Where else we cause microcephaly? Chickenpox. Whenever there is chickenpox infection in the early trimesters, again like a chicken, thin limb, small head, like that you can remember. Chickenpox also will have microcephaly, thin limbs, limb deformities will be there. Like similarly in Zika virus also there is microcephaly most commonly. Okay, hydrocephalus is more common seen in parvovirus infection. Okay. Okay, so I think your all 30 questions are completed now. So yesterday Shruti had asked me regarding the PMOS. I have made one more slide for that. Does anybody has any doubts for this? If not, I will just show 2-3 slides of PMOS and we can conclude the class. Just a second. Okay, all these things I had made, but I could not cover because of the time constraints. Just the important slides I will show you. So how to differentiate between a case of Mullerian agenesis and a case of this is an image of what? Yes, first you guys answer me. I will just show you the slides and we'll go ahead. So this is an image of imperforate hymen. What they've done is a cruciate incision. Okay, this is an image of hysteroscopy. You can see the hysteroscopic adhesions. Adhesions are there. That means it is a Asherman syndrome. Okay, then this is MRKH. Absent uterus is there, but there is pubic hair and axillary hair, and breast development is there. That means it is MRKH, Mayer-Rokitansky syndrome. Whereas if there is no pubic hair, no same patient with no pubic or axillary hair, and rest all are same features, it is 46XY. Then it becomes a androgen insensitivity syndrome or testicular feminization syndrome. Okay, so if they've given you history amenorrhea, no pubic and axillary hair, it is in terms of androgen insensitivity syndrome. If pubic hair and axillary hair is there, it is MRKH or uterine agenesis. Okay. See, this is your androgen insensitivity. Breast development is there, but there is no pubic and axillary hair. Okay. So this becomes your androgen insensitivity syndrome. Then is this your short, this is very important, okay, for features they would give for a Turner's many a times. She'll have primary amenorrhea, especially Turner's will have. Mosaic sometimes can have menstruation, but Turner's as such XO means will not have menstruation. Okay, short stature, web neck, high arched palate, cubitus valgus, shielded chest, widely placed nipples, low hairline, renal and serious abnormalities, and autoimmune disorders. Okay, these are the common features they would give you to suspect a case of Turner syndrome. A chromosome is 45XO. One chromosome is absent. And you should also know your classification uterine anomalies, agenesis and septate, bicornuate, diadelphys, all these things also. Okay. Hmm. This one. This is complete uterine agenesis, cervical agenesis, and here you can see unicornuate uterus, and here you can see uterine diadelphys, two separate uterus, and sometimes you can see two separate uterus and two separate cervix. That will be diadelphys with bicolus. Okay, bicornuate, bicolus, like that. Okay, here you can see bicornuate uterus. Okay, and here you can see transverse vaginal septum. It can be either vaginal septum or uterine septum. Okay. Then septate uterus. Septum can be in the center, it can be just minimal, it can be occluding one cavity, or it is extending into the cervix, or it is blocking into the vagina also, and it is blocking one part of the tube and the ovary and the uterine cavity, any of it. Then is your vaginal septum. Vaginal septum can be longitudinal, horizontal, launched in and then attached horizontally, any of that. And complex anomalies can also be there, combination of all these things. This semen values also you should remember. Of these, most important thing that you should remember is like this. Okay, so normal semen volume is 1.5 ml and 1.5 15 million. Easy to remember. Volume is 1.5 ml and it should have at least 15 million count of semen. Okay, in per ml. Okay, per ml should have 15 million count. Most important things only I'll tell. 32% should be progressively motile, and normal morphology should be at least 4%. Understood? 4% normal morphology. If not everything, at least these things you should remember. Okay. And these things also you should know. You can take an image screenshot. What is oligospermia? What is azoospermia? What is asthenospermia? What is teratospermia? Terato means abnormal sperms. Astheno means they where there is reduced motility. The sperm is not moving well. Azoospermia means complete absence of sperm. Oligo means reduced count of sperm. Okay, at least these first four definitions you should know. Rest all will be combination of the upper. Okay, coming to the PMOS, which you wanted to discuss. See, as such, it is just a name change. Don't have to panic. Something new came just before exam. Why for me? All these things you don't think now. It is just a name change. Why this name change also? Because patients were having really difficult. It is not for the doctor's sake. It is patient's sake. So everybody used to think cyst is there. That is why I'm having a problem. Remove the cyst. So that is why we changed the name from polycystic ovarian syndrome to polyendocrine metabolic. It is an endocrine metabolic syndrome, ovarian syndrome. Okay, it is not something only confined to ovary. It is a multidisciplinary team approach. Everybody, endocrinologist, a medicine, a dermatologist for hirsutism, everybody should be involved, not just a gynecologist to treat a PCOS. This was the key message to be passed. Okay, now coming to the new updates of this, the Rotterdam criteria is the new update. Otherwise there is no much update in this. PCOS, same, you know, insulin resistance is there. It is a metabolic syndrome where there is central obesity and hypertriglyceridemia. Ovarian dysfunction like menstrual irregularities and infertility are very common for this patient. Hyperandrogenism, signs like acne, hirsutism, everywhere you can see. Okay, these are the common. Then psychological problems like anxiety, depression, self-esteem is low, excessive hair growth is there, so they are not confident of themselves. This becomes the problem. Dermatological problems, again because of hirsutism, acne, all these things. Okay, and also hair fall, these things becomes a very important complaint. So you can see what is this. This is the acne picture. These peripheral cheeks become the more common areas. Okay, for your acne, inflammatory acne commonly seen on face, cheeks, chin and jawline. Okay, this becomes the common areas for pimples in case of a PMOS. Whereas hirsutism, you can see excessive hair growth. Okay, these are the clinical features. How to diagnose clinically? Clinical hyperandrogenism. Okay, it is not blood investigation where you're telling androgen is high. Then use your acanthosis nigrans, a sign of insulin resistance, isn't it? Velvety hyperpigmentation, thickening of the skin, commonly seen in the back of the neck. Okay, So coming to the Rotterdam criteria, the important thing that you should know is, anyways, all these things you know, two out of the three criteria should be there. Out of the two, out of the three, at least two should be positive. Either clinically having signs of hyperandrogenism, or biochemically, the blood values saying it as hyperandrogenism. Okay, whether there is a raised testosterone or a free testosterone, DHEAS and all are raised. And clinically, how do we say? It is either Farman-Galway scoring for the hirsutism. Okay, remember the name. Farman-Galway scoring is for the signs of hirsutism. It is on the face, chest, back, upper abdomen, lower limbs, and the hands. How is the hair growth? So everything is categorized. If it is Farman-Galway score of more than 4 and or more than 8, okay, then you suspect it has to be as a case of a hirsutism, or severe growth, hair growth is there. Okay, then one more clinical feature is oligo or amenorrhea. Okay, when they have repeated oligoamenorrhea is there, at least less than 8 menstrual cycles per year is happening. Okay, then you consider as oligomenorrhea. And then coming to the scan finding, which is the new update. Previously it was more than 20 follicles in both ovaries. It is now at least even one ovary has more than 12 follicles, which are peripherally arranged. Okay, so in the first image only I showed you. So you should not get confused between OHS's I don't have OHS's image, is it? Okay, this is a peripherally arranged cyst, isn't it? I'll show you the OHS's image also. I'll have. So the OHS's will not have like this. PMOS will have this peripherally arranged pearl of string appearance. Okay, it is called as pearl of string appearance. So this image, more than 12 follicles or more than 10 cc of volume is there. Then you consider it as a ultrasound finding positive for PCOS. Okay. Phenotypes, I'm not sure if they will ask you. Then coming to the PCOS, insulin resistance is there. So if somebody is obese and trying to conceive, you can add metformin to reduce the insulin resistance. Okay, pioglitazone if they're not planning to conceive. Then recommendation, if she is an adolescent patient, you can give her metformin for insulin resistance, and you can give her anti-androgens. Okay, you can give her metformin and anti-androgens for hirsutism. Whereas young patient, ovulation induction with or OC pills. If she is wanting to conceive, you will give ovulation induction. If she is not wanting pregnancy, you will give her OC pills for regularization of cycle. Then obese and hypertension is there, then you will give metformin and tell symptomatic. Symptomatic is nothing but lifestyle modification. If they have given you history, menstrual issues are there, then if she is wanting to conceive, you will give her progesterones only. You won't give estrogen. Okay, you will give her only progesterone. If she is not wanting to conceive, you will give her OC pills. Okay, androgen features are there, like hirsutism, acne and all is too much, then you will give anti-androgen containing OC pills. Okay, anti-androgen containing OC pills like Diene 35 for you, for example, if exam if they ask. Okay, Diene 35. And high risk patient is there. Okay, for example, high triglyceridemia, cardiac anomalies are there, obesity, hypertension, many other features also is there. Adult young stage only she has developed diabetes, then you can give her statins. Okay, this is for cholesterol. Then vitamin D supplementations and measures to prevent cancer. What cancer is more common in these people? PMOS and lifestyle changes. Okay, what cancer is more common? Let us end this class with this slide. And what cancer is more common for a PCOS patient? By the time you answer, I'll find out the OHSS picture for you. Endometrial, yes. Digvijay Singh has given the correct answer. Endometrial is the more common feature. Okay, now I'll just Google it and show it to you. I'm not finding the image in my slides. Mm. Like this, they'll give you the image. Okay, so this image you can see. So this image like this. Multiple big cysts are there inside. Okay, and they will give you history. She was on infertility treatment. After HCG, she's having this thing. She's having abdominal pain. Ascites is there. Bloating is there. She's not able to eat. She's not able to breathe. Like this complaint they will give you, and then this might be the image. That time you should tell she's a case of OHSS. Okay, as simple as that. Uterine cancer, endometrial cancer is the correct answer. Okay, so with this we'll conclude my live session. I hope you have enjoyed the classes and you will recollect also in your exams and you will answer it equally well in your exams. Okay. So if you have any doubts, you can contact me with my Facebook channel or my Instagram channel, and you can message me on the Telegram group, WhatsApp groups that you have joined, or you can directly message in the Diginerve app also. Okay. So I'll help you clear your doubts. Please don't go to the exam with any doubts. Make sure you have understood every concept and you have answered well, and then it will be easy for you only in the exams. Okay, so it is not very difficult to clear the exam. If someone X can do, you also can do. It only requires a good amount of concentration, and when you start studying the exam. Okay, that is the only key thing here. Okay, good amount of concentration when you are studying. I'm not asking you to read for 24 hours. Whenever you are reading, you read with good concentration. Now you should read little longer also, because you have to read 19 subjects also, isn't it? So you read longer with good concentration. Don't lose hope. Now if you lose hope, you will not be able to do it. Now is the time to get all your courage and study well. Okay, all the best, students. Thank you. Thank you. I hope you have understood.